show some resources for the risk coding that seem to raise some questions. If you go to the www.keymh.com, which stands for keymedicalhome.com, this is different from keymedicalhome.com. This is the site for our resources. So it's keymh.com. Go down here to ACO resources, highlight the risk coding resources. It'll take you to this screen which has all the different resources on it that we tried to accumulate. We've got the webinar slides that we did from a couple weeks ago. We've also got a recording of that webinar. There's some slides out there that explain what a patient risk score is. There's some Medicare risk adjustment slides directly from CMS. Dr. Meyer's presentation a couple weeks ago is out there with the slides. We've got the actual categories for HCC from CMS, and we've got a slide presentation on calculation of Medicare shared savings, as well as a lot of questions on quality measures. This is the summary, and then this is how those shared savings qualify for a payment on quality. One of the more important ones is the color-coded ICD-9 risk codes, and with 2014 coming, there's some changes, so we put both of them out there, both in a PDF and in a Excel format. So the Excel format you can sort to however you would like to do it. Let me just show you what the PDF file looks like here, because this is one of the key aspects. Anything in green codes in 2013 and 2014 for a risk score, and here I've included the 2014 risk scores. The other one that you want to focus on for at least through 2013 are the yellow ones. They won't have a risk score in 2014, but you will get credit for them in 2013. So if you see a code that's in a yellow highlight, that means it will risk adjust in 2013. So if you have this, you want to get this in for this before December 31st. The pink ones will all be the new ones for next year. So you want to add this to your problem list right now, but if you don't have enough room, you don't necessarily have to add that to your diagnosis that you file during a face-to-face encounter. So you want to do green, you want to do yellow for 2013. The pink ones, if you have room for them, at least put them on your problem list. But white ones do not risk adjust. So any white ICD-9 code here will not risk adjust. So those you want to put as your lower priority during your face-to-face. You don't need to necessarily get all of those in for 2013. There's a comprehensive risk toolkit here that basically has all the things that you would need, all the risk scores and all the categories. And then there's the risk weights, if you're interested in what the weights are for 2013. Like I say, we have the weights out here for 2014, but 2013's weights are right here. There's some tip sheets for coding. These, let's take a look here real quick. Just hypertension goes through the different ones, the diabetes and the manifestations of diabetes, and then the major depressive algorithms, and then some things that you may want to keep an eye on, HIV and alcohol dependence and things like that that you need to remember to do each year. There's a quick reference for risk coding. It's several pages, a summary. It's a pretty good thing if you want to keep handy on your exam room. And then there's some summary slides of some helpful hints and tips. There's examples of risk calculations, but one of the more important things that I wanted to take a look at is this calculate a risk score for my patients. You can do it for any year. I like to do 2014 to show what the difference is going to be. You have to type in a date for the patient. Of course, they're going to have to be something that would be of Medicare age. We'll just put anything in here. You can put anything in here because this will change your demographic score. Your birth date in male or female will change your demographic score, as is if they're Medicaid eligible or if they're institutionalized. The other category that gets an additional geographic risk factor is the disability. So just to show you the differences here, if your patient has hypertension and CHF and you start now coding the 402.11, you also put the CHF code in. Let's just show some examples of diabetes. If you use the 250.40 for the renal manifestations, and then they have, say, chronic kidney disease stage 3, and we'll put also in the ophthalmologic code 250.50 complication and the retinopathy code. And let's also just put some old ones here, the old MI code for 412 rather than coronary disease 414.01. And I'm going to put in asbestosis here just to show you something. So you hit submit, and this will give you your entire risk score. What you're going to see here is that CHF and the hypertension with heart disease, the 402.11 and 428, go to the same HCC category. So you're only going to get credit for one of these. So when you see this Y override in here, that means it's been overridden by one of the other codes. So basically, you're only going to get the 0.346 credit in 2013 or the 0.368 credit in 2014. But you still want to put both codes in because it does change a lot of interactions and other things that are important. And looking at the diabetes codes here, the 250.40, the renal, you see you get 0.371 in 2013, 0.368 in 2014. You get credit in 2013, so it's important to put these chronic kidney disease stage 1 through 3 in for 2013, but you will not get credit for anything 1 through 3 in 2014, only 4, 5, and end-stage renal disease. Same thing with the ophthalmology complications of diabetes. You see it codes to the category similar to the diabetes with renal, so you're only going to get credit for one of these 0.371s, or in 2014, the 0.368. So, but you still put them both in because now you're getting credit for your diabetic retinopathy for 2013. However, the key thing here is, and this is why I use diabetic retinopathy. I'm sorry, I used this code to show you something here, that in 2014, diabetic retinopathy will code to the same as diabetes, so you will not get credit for it. However, if you use the proliferative retinopathy or any of the other codes that it's more accurate, you will get risk score for both 2013 and 2014. So this is just an example to show you that in 2014, this is going to be coding to the same category as the 250.50. And then the old MI 412 goes to category 83, but you see in 2014 you will not get credit for it. And same with asbestosis. In 2013, you're not getting credit for it, but in 2014, you won. So this is one of those pink codes that we saw on the sheet. The old myocardial infarction is one of the yellow codes, and then all of these other codes are green. And then it goes down here and gives you your demographics, your total risk score. It normalizes it. And as we've talked about before, you get the blending for 2014. 25% of this score, the 1.88, is added to 75% of the 1.372, and you get a risk score of 1.501. So again, all of this is on the website. And like I say, if you have questions, I think this calculation is a good place to go for that. Just take a quick look at some of these examples. Let me just start the show here. 68-year-old presents for evaluation of chest pain with exertion, relieved with nitroglycerin. Past history, AFib, old MI, alcoholic cardiomyopathy, COPD, 40-pack history of smoking, CVA with hemiplegia, creatinine chronically elevated, GFR low, has a white count of 18,000 for 4 years, stable CLL, alcoholic cirrhosis times 10 years, stable, the liver functions have been stable but have been elevated before, triglycerides are up, drinks 3 to 4 martinis a day for more than 15 years, and does have a history of asbestosis. So a lot going on here, but just to show you how the coding matters. If you just coded this as chest pain, 786.50, you would get no risk score, but angina, which it sounded more like, is 4.13.9, and you do get risk score for that. Same thing with the history of the arrhythmias. The AFib gets risk scores, the arrhythmias doesn't. Cardiomegaly is just a basic 429.3 code, gets nothing because it's not specific enough, but alcoholic cardiomyopathy does. Coronary artery disease, as we said before, does not. The old MI does. However, in this example, old MI is coding to the same HCC code as the angina code, so you get only credit for the one. The history of stroke, the V12.54, which is the appropriate code for people that have had stroke. Remember, the acute code is only in the hospital, and it should not be used. The stroke with hemiplegia, though, is what this person actually had, so you use the late effect codes, 438, and you will get risk scores for these in both 2013 and 14. If you use the generic chronic renal insufficiency, you will still get credit for the risk, but if you use the more specific CKD stage 3, you're going to get the credit in 2013, but in 2014 it's going to go away. Same for the 585.9. Abnormal white cell, you know, they have an 18,000 white count. It's been that way for a while. CLL, but if you use the code 288.9, you're going to get no risk score, but if you use the actual CLL code, you are going to get a risk-adjusted score. Same thing with the history of the elevated liver test. Now they're normal, but the more important diagnosis is the alcoholic cirrhosis, which gets you a .412 risk score compared to a .399 in 2014. So again, using the more specific. The triglycerides, cholesterol, things like that are going to get 0 risk scores, but you should include them at some point. But again, these are going to be your white codes on your color-coded sheet. These are the ones you're not going to get any risk score for. Remember, abuse versus dependence. I think it's easy to document in this person they're dependent. You'll get a risk score for the dependence. You do not get it for the abuse. Tobacco abuse, since they're a 40-pack-year smoker, you're going to get no risk score, but the COPD, you do get a risk score for. Demographics, this is going to be just the 68-year-old white male, and you're going to get a risk score, and it's going to change a little bit in 2014. But there's some interactions here, COPD and CHF, COPD, CVD, and CAD. All of these interaction scores, including the renal failure and CHF, give you almost another .75 risk score. And I put here asbestosis. If you include it this year, you're going to get nothing, but next year when you code it, you will get .274. So when you see in this person, if you're just putting these non-specific things, you're getting a very low risk score. But when you actually normalize, get a normalized, or before a normalized score for 2014 and 2013, you're going to see a slight difference of .5 because you're losing a couple things here, the chronic kidney disease, and you're gaining the asbestosis, and you're losing some of these interaction codes in 2014. But again, you can look through that, and then your normalized risk score is .25 times your 2013 score and .75 times your 2014 score. Another example, a 72-year-old white female for evaluation has an ileostomy, a history of breast cancer, on tamoxifen, obesity. She's more in a BMI of more than 40. She has a mood disorder. She's been stable on meds for 4 years. Polymyalgia rheumatica for 3 years, controlled with medications. Hepatitis C from a blood transfusion 3 years ago. She's had paroxysmal atrial fib. She's on meds, stable for that. She prints with the shoulder pain and infection, the stage 3 pressure ulcer on her buttocks and depression symptoms for 1 week after the death of her husband. She was seen last week in the ophthalmologist's office and diagnosed with proliferative retinopathy. She has the ileostomy from previous colon surgery. She has an elevated fasting blood sugar for a year, but her hemoglobin A1C has been between 6.2 and 7. She's received no treatment for diabetes. However, the provider continues just to document sugar intolerance. I should note that that treatment, I mean by pharmacological treatment, of course, you are suggesting diet and exercise and other non-pharmacologic treatments for this lady. So the shoulder pain, if you just document it's the shoulder pain, you're going to get 0, but she's had chronic polymyalgia rheumatica. If you document that as your diagnosis, you're actually going to get your risk score. She has the 1 week of depression, but she's also had a long history of mood disorder, which you've been treating, and this is acute exacerbation of that. So as long as you're documenting the previous history and how it interacts with current, and use the 296.90 code, as long as that documentation supports it. Remember, an acute depression from a loss or something like that has to be 311, but if you're also taking into consideration treatment, her old diagnosis that you've been treating for a while in medicines, you can include that. Cellulitis of her buttocks is going to get you nothing. You have to use the pressure ulcer stage 3 pressure code. Obesity gets you nothing in 2013, but in 2014 we get a .365, so it's important to start coding this. 278.01. Tachycardia versus paroxysmal ventricular tachycardia, you're going to see you get really nothing for the tachycardia, but you put the more specific diagnosis in, you're going to get that. And hepatitis, if you just use a regular hepatitis code, you're going to get nothing. If you use a chronic hepatitis C code, 070.54, you're going to get the risk score. Again, this patient has an elevated fasting blood sugar, but really has diabetes with now ophthalmologic issues. So you will get credit for the .371 there. The retinopathy code for the proliferative retinopathy, you will get a risk code in both 2013 and 2014. This is what we talked about when we were using the website and showing that if you use this code, you will get credit as opposed to just the diabetic retinopathy if it's appropriate. And the ileostomy, of course, a lot of people forget about that, so you want to make sure you put that in. You do get a risk code for that. But if you don't put it in that year, you get nothing. In the history of the breast cancer, if you use that rather than they're on the tamoxifen, the V10 code, you're going to get no risk score. But since they're on adjuvant therapy, you can use the 174.9 code. Of course, you're going to get your demographic score. And this gives you your total risk score before you normalize. And again, 2014 score will be determined by taking 25% of the 2013 score and 75% of the 2014 score. So our last one, 80-year-old with a history of heart transplant 4 years ago, was treated for systolic heart failure, diabetes, esophageal varices. Those are stable, hypertension, peripheral neuropathy from diabetes, chronic GFR, has some peripheral vascular disease secondary to diabetes, and over the past 2 years has developed a chronic encephalopathy and portal hypertension with daily confusion from cirrhosis of the liver. She also requires continuous oxygen from chronic emphysema. So let's see what happens here. Well, again, if we just use a basic heart failure code 428 and not the specific code, you're going to get nothing. Now, in the diabetes, again, if you use the uncomplicated, you're going to get the 0.127. But we said she has, or he has diabetes with peripheral vascular disease, so you're going to use the 250.70. The peripheral neuropathy, this does not risk adjust in 2014, but it does in 2013 if you use the 333 or 337.1. But if you use polyneuropathy and diabetes 357.2, it gets you the same risk score. However, in 2014, that's going to be overridden again by your 250.70 code because the diabetic codes are all going to start, rather than being in 5 classes, they're going to be in 3 classes, and they're going to override. But you still want to include them all. Hypertension, again, if you use the hypertensive heart and kidney disease, it's going to be overridden by your heart failure, but you want to be more specific, so you always want to use your specific code. And then the chronic kidney disease we've talked about will not risk adjust in 2014, but will risk adjust in 2013, so you want to include that. And if you use a non-specific peripheral vascular disease, you're still going to get credit, but in 2014, you won't get credit for that, so you want to use a more specific peripheral vascular disease from diabetes, and you will get credit in 2013 and 2014. Cirrhosis, again, that's going to be in 2013 or 2014, but when you start using complication type diagnosis like portal hypertension, encephalopathy, some of those are going to override your basic diagnosis. So in this case, portal hypertension will override that cirrhosis diagnosis. Your encephalopathy code will still get risk adjusted even though it's part of the disease, but you will not get credit for the cirrhosis, but you want to include all of those. Now, if you just include generic emphysema 492, you're going to get 0 risk score. You've got to make sure you use the 492.0 or 492.8 or one of the more specific codes. And as you see in 2013, if you don't put a lot, you don't get a very high risk score unless you put a lot of these things in. But esophageal varices, even though they're non-bleeding, you want to put those in. But again, in this case, all of this is related to liver, so you're only going to really get credit for the hypertension and the encephalopathy. Those are going to be the overriding ones. Hypoxemia does risk adjust in 2013, so if they're on oxygen, you want to use that. Again, you're going to put your diabetes with renal in because you have your renal disease. You're going to put your diabetes with neuro in because you have neuropathy. But they're only going to be overridden by one. You're only going to get credit for 1250.13456, whatever your complication code is. And remember, heart transplant or any kind of transplant you want to keep in there because you'll get credit for that. Even though it's stable 4 years, you want to do that. Then you get your interaction codes, CHF and COPD, and CHF and renal failure and diabetes. You're going to get that interaction, but you're going to see in 2014 it's just going to change to diabetes and CHF, and you're only going to get a 0.182 as opposed to 0.6. And then you get your demographics, and you get your total risk scores there. Just a couple quick comments on the hypertension codes, just to show you that when you do code the hypertension 402.10 codes without heart failure, you get no risk scores. So risk scores don't get anything without heart failure. With heart failure, you do get risk scores, but if you include the cardiomyopathy or the CHF codes, the 428, you're only going to get credit for one of the 3 of these, but again, you somehow want to get them all in for the year for the interactions, and especially since some of these things change. Same thing with the kidney disease. You want to get you're going to get nothing if it's kidney disease stage 1 through 4, but if it's 5 or end stage, you will get something in the 404.11. And you do this year get credit for all of the CKD stages. Next year, only 4, 5, and end stage renal. You will also get credit by using the 404 codes and the 403 codes when appropriate here. You'll get credit for the 250.40 diabetes with renal if you have it documented. So you're going to get credit for all of those. However, you're only going to get credit for one of these codes, the 404, 403, or 585 code. But if you have diabetes too, you will get credit for that. And then finally, the same procedure here. You're basically not going to get anything without heart failure stage 1 and 4, but everything else does risk adjust. And then the risk scores are going to change 2013 and 14, but it's going to show you right here that if you have diabetes and you have the 404, 404.11, you're going to get a risk score for all 3 of those, as opposed to 250 when you get the 404.11s or .12s or the 404.13s plus the 428. You get all but the 428 codes because they all go to the same HCC. So basically, you want to put all these codes in, and you're going to get some credits for the highest HCC category. But unless you know them off by heart, you always want to put all these codes in, especially if you document it.